Hi, my name is Maya, and I'm from Fremont, Nebraska.
Hi, my name is Maddie, and I'm from Albert Lee, Minnesota.
I'm Katie, and I'm from Waconia, Minnesota.
So our group was extremely interested in hospital-acquired delirium and the effects of a sleep protocol in the inpatient setting. I personally spent my summer working overnights on an orthopedic unit in a hospital here in Sioux Falls. I quickly became aware of how frequently nurses are in patient rooms throughout the night and how many times we actually wake our patients up from restful sleep. When collaborating with my team members, I learned that they also had experience with waking patients up and experience with patients who had developed hospital-acquired delirium and other complications following interrupted sleep during the recovery process. We know that sleep is necessary to the healing process. When a client is in the hospital for a sickness, injury, or otherwise, the body responds with physiological stress, which in turn increases the patient's need for restful sleep. Deprivation of restful sleep can lead to multiple physical and psychological alterations in the body. Slowed healing process, increased perception of pain, high blood pressure, increased heart rate, heightened stress, and delirium, to name a few. Our PICO question for the project was, in hospitalized patients, how does sleep hygiene compared with the standard of care affect patient sleep quality? The databases we used for this evidence were TRIP, EBSCOhost, PubMed, and Lippincott. The search terms that we used to narrow down the amount of articles were inpatient population, uninterrupted sleep, sleep hygiene, and standard of care. We then used limiters such as scholarly articles that were published in English within the last 5 years.
Our evidence table for this study on the promotion of sleep hygiene consisted of 3 different levels of studies, which were 2 level 3 studies, a qualitative and a mixed methods, 1 level 4 study, a clinical review, and 2 level 5 studies, an organizational experience, and an integrative review. From the evidence found on the topic of sleep hygiene, data shows that more research needs to be done in order to fully understand the topic within the inpatient setting. Data shows that sleep is an important part of physiologic and mental restoration for the body. When sleep is decreased in the inpatient setting, the patient is at risk for the disturbance of a healthy immune system, emotional well-being, and the restoration of the body that occurs each night while asleep. Patients are also at an increased risk for the development of hospital-acquired delirium and increased pain perception. Patient reports also show that routine care and medication administration throughout the night both affect both the quality and quantity of sleep received while hospitalized. If a patient is stable, physicians say that coordinating and clustering care is a necessary step to take in order to minimize the disruptions of the sleep cycle to help the inpatient population heal.
So, as Maya said, our results indicated that sleep preservation is very important in the hospital. We also found that there is a great need for more high-quality research done on this topic of sleep quality in the hospital setting. Because of this, we recommend that a pilot study should be conducted. An EBP team should be assembled that will be able to brainstorm a low-cost approach to sleep promotion for patients staying overnight in the hospital. This study could be establishing criteria of the amount of knowledge on the particular topic that the nurses and providers have who will participate. Upon completion of the pilot study, an analysis of the patient outcomes would be performed. Determining more high-quality evidence in this area and eventually applying it to clinical practice measures could improve patient outcomes and prevent hospital costs that result from complications contributed to by sleep deprivation. And this could include hospital-acquired delirium, slowed healing process, and some of the other complications that Maddie mentioned earlier. Proposed evaluation of the results consists of looking at both the sleep quantity and the sleep quality of patients experienced in the hospital. The sleep quantity can be measured by quantitative means, measuring the number of hours the patient was able to sleep, as well as the number of interruptions by staff throughout nighttime hours that impaired the hours of sleep. Sleep quality would be best assessed by gathering patient surveys. So now to break this down further, we'll look at how the quadruple aim is impacted on this topic. So as I mentioned before, Sleep promotion interventions and minimizing sleep disruptions will improve patient outcomes with sleep quality, quantity, vital signs, perceived pain, and it will decrease the risk of patients developing hospital-acquired delirium, as well as those other complications once again. The population health that we would be looking at would be hospitalized patients, and this would improve their health because it increases their perceived well-being, increases their healing, and decreases their complications. Interventions will also be cost-effective for hospitals and save them money because it reduces the length of stay for the patients hospitalized. Finally, the care team's well-being would be increased because healthcare workers are interested in the idea of sleep hygiene to promote their patients' health and recovery. And this would also help the providers and other professionals meet their individualized patient goals.
So in terms of feasibility, our group discussed there were probably about 3 main feasibility factors that play into the study. The biggest would be forming that evidence-based practice team consisting of just people who can be well educated on the topic of sleep hygiene, and they would educate the physicians, nurses, patients, and any other healthcare personnel involved in the study. And the reason why this is probably the biggest feasibility option is just compensating those workers for doing the work of being very educated on that subject. And then some other feasibility options of pretty low cost would be just the creation and lamination of posters to put on the patient's door saying, "Do not disturb," as they are part of the sleep hygiene study. And then another cost to the study would be the creation of those surveys and questionnaires for the patients after they have completed the study. But one way to decrease this would be to have a healthcare personnel or have the patient complete the study at a follow-up visit just to reduce the cost of postage.
So the impact on nursing is implementing a sleep protocol or the pilot study would impact nursing practice depending on the patient's status. So the nurse needs to be aware if her patients are stable or in critical condition. If the nurse was able to be a part of the EBP team to participate in the study and gain that knowledge before it actually hit the floor or the hospital. An example of how this could look on the inpatient setting would be that nurses that have stable patients would be able to interrupt the client's sleep once or twice during a specific sleep hours. And in this time, the nurse would cluster as many cares as able and could actually lead to decreased amount of nurse burnout because the nurses wouldn't have the time aspect putting the stress on their jobs, getting everything done by a certain time. This would allow for more time for nurses to answer call lights for patients that do wake up and ask for help. It would allow for more accurate charting. And it would allow for more time to take care of patients that aren't in that stable condition. So overall, we think that it would be a very interesting study to take part in and have in the hospital just to see if it really does improve the sleep quality, quantity, and increase patient outcomes post-discharge.
Thank you.